So good afternoon, everyone. My name is Carolyn, and I'm the Alumni Relations and Annual Fund Officer at Bloomberg Nursing. Welcome, and thank you so much for joining us for today's Lunch and Learn session, Healing the Hurt, Culturally Safe Care for Indigenous Families, featuring Dr. Amy Wright and Rachel Van Every. Before we get started, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So before we get started, I'd just like to go over a few housekeeping items. Since there are so many of us, we ask that you stay muted throughout the presentation. We welcome you to enter your questions in the chat box, and there will be a Q&A period at the end of the presentation. This session will also be recorded so we can share it with those who are not able to join us today. We'll send you an email after the session, which will include the link to the recording, as well as an opportunity for you to provide feedback on today's event. Apologies. My notes. So now it is my pleasure to introduce today's speakers, Dr. Amy Wright. Dr. Wright is an assistant professor at the Lawrence S. Bloomberg Faculty of Nursing and a neonatal nurse practitioner at McMaster's Children's Hospital. Dr. Wright has worked with the Indigenous community in Hamilton since 2013, assisting Indigenous-led organizations in meeting their research goals as they relate to healthy parenting and early childhood development. Rachel Van Every is a PhD candidate in the Department of Health, Aging, and Society at McMaster University. Thank you both for joining us today. Now over to you.
Great, thanks so much for having us. We're really happy to be here today. It's an exciting project to talk about, and we're really thrilled for the opportunity to get the word out there about this resource. I wanted to add that Rachel and I have worked with each other for almost a decade now on projects with the Hamilton Regional Indian Center, the Friendship Center in Hamilton, helping them to meet their research needs as it relates to parenting and early childhood. Rachel is also a PhD candidate and doing some work in the area as well, more focused on poverty. Rachel, do you want to say anything else before we get started?
Yeah, thank you for inviting us to speak. It's a privilege to share our work with you, and I'm looking forward to our meeting today.
So we also just wanted to say a word to acknowledge the National Day for Truth and Reconciliation, which falls on September 30th. This is a day that's a reminder of the responsibility that we all have to learn about our colonial history and its previous and continued impact on the lives of Indigenous people. Rachel and I are privileged to live, work, and play on the traditional territories of the Mississauga and Haudenosaunee nations and on the lands protected by the Dish with One Spoon Wampum Agreement. The picture here depicts the two-row wampum belt agreement, which was made between the Dutch settlers and the Haudenosaunee people of the region to live together in harmony. There are many stories of its meaning, but in one, the purple lines are said to represent the ways of the Haudenosaunee and the European settlers, and the one row is a ship with the settler ways, and in the other, a canoe with the Haudenosaunee ways. It is said that each will travel down the river of life side by side, and neither will attempt to steer the other's vessel. There were three principles agreed upon to make this treaty last, including friendship, peace, and that the agreement should last forever. Today, it is applicable to all settlers and our relationships with Indigenous people. As we will share next, the Healing the Hurt campaign is one way that we show our commitment to this treaty through treating one another with kindness, respect, promoting friendship, and peaceful relationships.
Yeah, so thanks again for joining us today. I see a few people are still joining. So right now we are talking about the Healing the Hurt campaign, which originated from moms who participated in a study with Dr. Wright about their experiences using healthcare services for their infants. We are very thankful for the moms who shared their stories and continue to work with us to make a real impact with health professionals. One of the mothers from the study suggested documenting their experiences in a video, and the idea took off. We managed to secure funding from the Canadian Institute of Health Research and created an advisory group. The group met regularly over the period of approximately 1 year before the videos were finalized. And the group included mothers, including those you see in the videos and are on our social media posts, as well as First Nations early childhood service providers, nurses, and 2 nurse practitioners, and an Indigenous knowledge holder. Together, at the direction of mothers, the advisory group created this project to reach health providers and students in health provider programs from across the country, and our goal is to promote culturally safe healthcare practices for Indigenous families. You can view the videos on our website at indigenousmomandbaby.org and view additional videos and content on our Facebook, Twitter, and Instagram pages. Next, we are going to play the trailer for one of our videos. The content may be upsetting. It may also be difficult to fully understand the injustices faced by these mothers. It's important, however, to hear their stories and acknowledge their experiences and pain so that we can also recognize what we can do better to provide culturally safe care for Indigenous families.
I woke up January 2nd and I begged my husband to not go to work because I knew today was the day she was going to be born. I didn't know that January 2nd would be the day that she died. And they stripped my daughter naked. The doctor looked up and she said to me, "I'm looking for bite marks, burns, and bruising." I didn't understand why. There was no signs of neglect or abuse. I was the one who wanted to be referred. I didn't even go back for 2 months because I was so scared to see her and talk to her because I feel like she was going to make me feel bad. It makes you wish that you weren't Native. It makes you wish that you were any other race but that. I wasn't married at the time. I lived in Native housing. I was on welfare. I was a statistic. I wasn't a human being. The way we're treated, it affects us. You have the power to save people's lives. And I don't think a lot of them realize that. I woke up January 2nd.
Sorry. Okay, I always have to take a breath after that. The mothers involved in the original research project spoke to their experiences engaging with healthcare, and that included their experiences with family doctors, emergency rooms, specialty care, and others. And today we're going to share 3 important messages that these mothers had for health providers to improve their healthcare experiences. These included building relationships, providing holistic care, and taking a sensitive approach to child protection. We'll go through each separately. Okay. To further describe how to build trusting relationships with Indigenous mothers, we'll discuss 5 strategies. First, effective communication skills. This includes active listening, updating parents on your plans of care, as well as interacting with their children. A nurse's use of effective communication skills has actually been shown to increase parent confidence in our knowledge and in our skills. And it decreases and reduces parental stress, anxiety, and depression. Non-judgmental care is a second important piece of this. And given the history of residential schools and historical trauma, as well as the possibility of current trauma related to social inequities such as poverty, Indigenous mothers that we spoke to were also young, and they shared that they felt being judged because of being a young mother. Feeling judged left them with feelings of anxiety about their children being apprehended. And we know that the rates of child apprehension amongst Indigenous families is extremely high in Canada. So this is, there is good reason for families to be scared of this. But providing non-judgmental care is one way that we can help build trust in relationships with moms. Another is enabling trust. Building rapport with families, taking that time and recognizing that building trust does take time. So it does mean, setting aside some time during your day, which I know is really hard these days. Healthcare is an incredibly busy place, but we need to prioritize building trust with our families and our patients because it's essential to being able to meet their needs. Collaborative decision making. Again, I know this takes time. All of this to provide care and build relationships takes time, but we need to try our best to make decisions collaboratively with families. It's an important component of the family-centered care model. The mothers talked about really feeling that they wanted to be supported in their decision to breastfeed. This was important to them bonding with their babies, and taking that time to make a decision collaboratively with the family before giving bottles, providing formula, that kind of thing. Also taking an individualized approach. Just because families have previous children does not mean that parents are confident in their abilities to take care of their newborn right off the bat. So rather than making assumptions that the mother with a few children is able to provide that first initial bath with their newborns, the mothers really wanted to be asked about their confidence as well as supported in those skills, because if any of you have had newborns, it's quite a bit of a hazy time in your life. So try not to make assumptions that parents have those skills or remember those skills, because it is, it's a busy time. Your head is clouded, and it's nice that when parents have the support in making those decisions and building those skills again during that transition time in their life. As well as consistent care. Again, this sort of helps with, if you're seeing families over and over, this can still take place in the acute care area. I work in the neonatal ICU, and having consistent nurses that come back and care for those families over and over really helps to build relationships. And that's really key, with these families. They have good reason not to trust us as health providers, given our history as health providers in Canada and some of the roles we've played perpetuating stereotypes, racism, discriminatory care, as well as the residential schools, Indian hospitals. We as nurses have played a role, and we need to recognize that role and do our utmost to help build relationships, establish trust with families that are coming with this trauma embedded in their lives already.
Yeah, so the second important component that we learned from the research is related to holistic care. And so to many Indigenous people, health and well-being can be symbolized by the medicine wheel, which encompasses physical, emotional, mental, and spiritual health. So in this study, mothers were asked to reflect on these holistic needs of their infant, and they all agreed that health providers met their infant's physical health needs, which to them meant treating illness, supporting feeding, and promoting breastfeeding. With the emotional needs of their infants, these included things like comforting their infant, fostering feelings of safety, and providing love and attention. One mother shared her experience of waiting 3 days before she was offered the opportunity to hold her infant, and as a result, She did not feel the health providers had met her infant's emotional needs because they had denied him the access or him of the comfort of his mother. The infant's mental or developmental needs included their cognitive and motor skill progression. Mother shared that these needs were met after their hospital experience and not during. This likely reflects a lack of communication on the part of the healthcare provider in sharing how they are meeting these needs of infants. And so as health professionals, we also need to recognize the developmental needs of infants in the hospital as important and sharing this information with parents. With the spiritual needs of infants, these are supported by understanding cultural practices surrounding the birth of the infant, including being thankful for the infant as they are a gift, implementing cultural practices such as smudging, praying, songs, things like returning the umbilical cord or the placenta to Mother Earth, the use of cedar baths, and is celebrating the infant's beginning of life and development of their identity. These needs, however, were not seen as being met by health providers, and in some cases, they were prohibited. One mother also shared how breastfeeding supported her infant's spiritual health, as she believed this bonded their spirit when breastfeeding. So some other strategies for providing holistic care and meeting the emotional, mental, and spiritual needs for those who care for Indigenous families with newborns in the hospital include things like implementing smudging protocols so families can engage in smudging while in hospital, access to culturally safe spaces where families can gather, pray, sing, and engage in traditional aspects of their culture while in a hospital, access to Indigenous elders, traditional healers and knowledge holders, access to natural medicines and ceremonies, and as well as promoting connection and access to Indigenous patient navigators or advocates, as well as local Indigenous friendship centers or Indigenous health centers within proximity to the hospital. I also wanted to share a few cultural tools and practices that are meaningful to me. I am Six Nations, I'm Mohawk, sorry, and I live on the Six Nations Reserve. And I just wanted to highlight the meaning of these different tools that I use and how they can be utilized by health providers within a setting such as in hospital. So these are tools that I've gathered or were given to me by family members or people in my community. They're actually scattered across various places in my home. I have 3 children, so I believe that they're all beneficial for providing reminders and a connection to our culture to my children. And they also build skills in sensory development for my children as well. So all these items can be handcrafted or found at local craft stores in First Nations communities like my own. And me and my husband, we tried to make things out of material as well that we can find outside with our children. And together we've learned how to make different things like medicine pouches. We've made miniature birch canoes, corn husk dolls, braiding different things. There's also a lot of teachings that can be shared with when making crafts or simply when holding or providing these items and sharing them with your children and your infants. For example, for me, the corn husk doll is really meaningful. It's significant to my family as well, as the doll is really a reminder that beauty is found within and the importance of having a good mind. And so when caring for Indigenous families with newborns in the hospital, some families may want their newborn also to wear things like moccasins or a leather bracelet around their wrists. So making them available and okay to wear the same way things like baby hats are available for newborns is one way that you can integrate culturally safe practices in a hospital. Yeah, and so I just call all these items like part of my medicine box. And if you have any more questions, I'm happy to answer them.
Thanks, Rachel. Our third topic was how to take a sensitive approach to child protection. For some mothers, their involvement with child protection services has continued to haunt them through subsequent pregnancies and led to racist and discriminatory care. The Murdered and Missing Indigenous Women and Girls report has since described this process as birth alerts or flagging, and they've deemed it deemed it dangerous as it has led to mothers not seeking care during their pregnancy and birth in order to avoid discriminatory care and judgment, or because of fear that their children would be apprehended. At the recommendation of this report, the practice has since been eliminated in Ontario, but this has only happened in the last 2 years. Given the history of residential schools and the 60s scoop, where children were forcibly removed from their homes, many to be adopted into families across the globe before parents could even locate them, it's no wonder that Indigenous mothers are extremely fearful when child services are involved. When clinicians involve child services in sensitive ways, mothers feel threatened and judged, and they're a lot less likely to interact with health providers in the future. When we take a trauma-informed approach to involving child services, we first understand the historical trauma that's been endured by Indigenous families and recognize the role of social and contextual factors, how they're impacting families, and first work to minimize and eliminate inequities rather than punishing families for these. Social workers should be involved when they can to support families, but at the same time, health providers also need to have these skills. I know in the neonatal ICU, it's, we're fortunate to have social workers who have, knowledge of local services and programs, but us as nurses also need to know what those programs and services are, because often on the weekend and certainly on nights, there are no social workers. So if we aren't equipped as nurses to help families meet some of the inequity that they are living with, then we're doing a disservice to these families. So we need to be aware of what local resources are available as well, so that we can also link families with supports in their community or in our community if families happen to be having care outside their community. Private areas as well, we should be sure to use private areas for sensitive conversations where they can't be overheard by others. And we should try to base our conversations on strengths and be supportive of families. A non-judgmental approach is super important. And when child protection services must be involved with an Indigenous family, which will happen, an Indigenous advocate is actually required to be present to support the family. And this is a fantastic way to make sure that local and Indigenous focused and led support are actually made available to family members who need them, so that they can have culturally safe care as they move forward. Many mothers shared how involving child protection services was used as a threat to avoid missing appointments. If you don't make this appointment, we're going to have to call CAS. This is extremely harmful and dangerous, and is totally inappropriate and should never be used as a threat. Taking a trauma-informed approach to caring for Indigenous families means recognizing that can cause major harm and actually lead to avoidance of the healthcare system, which means that we're not able to meet parents' needs. When we actually take an approach that is trauma-informed, that is building relationships, that is taking the time to build trust, and we build on strengths, then we actually are supporting people to feel comfortable to share their needs with us. And when they share their needs and they're honest about their needs, then we can actually care for them well. So it's important to do your best to provide care in this way, in a culturally safe way, to educate yourself on. There's a lot of resources available now. Healing the Hurt is one of them. But to educate yourself on the history of colonization, on some of these historical and current events, and so that you have a foundation when caring for Indigenous families. So in summary, the Healing the Hurt campaign was created with Indigenous mothers who wanted to share their stories to clinicians to stimulate transformative change in attitudes, beliefs, and care delivery. Many healthcare and educational institutions are seeking ways to educate their students and their staff on Indigenous health and cultural safety. And the Healing the Hurt initiative is actually an educational resource that can be used as part of a comprehensive curriculum on Indigenous health equity and cultural safety. Our website also provides more details of the study findings, as well as links to resources that can help you support your self-study about the history of Indigenous peoples in Canada, culturally safe care, and health equity. Our social media sites post content weekly to help you continue learning more about how healthcare impacts families. We invite you to visit our website and to follow our social media sites to learn more. All that information is on the screen for you. And thanks very much for having us speak today.
Well, thank you both for that great presentation. Very informative and timely topic. So we can have a Q&A now. So if anyone has any questions for Dr. Wright or Rachel, please feel free to enter them in the chat box or raise your hand, and you can unmute yourself to ask your question. We'll just give everyone a moment to type in a question if they're interested. Okay, I don't see anything. So I do want to thank you both again, Dr. Wright and Rachel. Oh, actually, we do have a question there from Jean. Jean, do you want to unmute yourself?
Yes, we've recently in Montreal had reports of birth alert, and I guess the thing that would be most helpful would be to know from the mothers in your study what they have been able to do to prevent this happening. Does that make sense? I can.
I'm not sure that the mothers have necessarily prevented it from happening, except through sharing their stories and through sharing their stories of what happens when there are birth alerts. They've managed, in particular with the Murder and Missing Indigenous Women and Girls report, which spoke to many of these mothers, they were able to make policy change based on sharing their experiences. But yeah, I mean, if you receive these birth alerts, I don't know if some of you have seen them. I know in the NICU, we get these faxes from, saying that there are these particular women, this was their name, this is when they're thought to be due. If you see any of them come in to deliver, you should call child services right away. And it really does create this sense of prejudgment on families, and taints the opinions of their caregivers from the get-go. And so rather than giving families the opportunity to come in and birth without judgment, people are automatically going in with preconceived assumptions about them. So it's extremely harmful. Yeah, and sometimes in these cases, children are apprehended in this way, and so parents are already not even wanting to come into the hospital to have their infants because they may be faced with them being taken away right away. So it's a horrible practice, and I'm glad Ontario has. I actually am not sure what the other provinces are doing, but I know Ontario has stopped the practice, which is great.
If anyone else knows what the other provinces are doing, I'd like to hear that.
We have another question also in the chat.
Yeah.
From Michelle. She said, have you seen policy changes that helps moms and babies?
So that's, I guess, it's kind of a broad question. There are lots of policies, certainly. I guess maybe you're talking about the birth context. And I can't say that I have. There may be local, like organizational level policies that are, I think one of the biggest policies, maybe organizationally and within our educational institutions, is ensuring that our staff and our students and health professions are receiving education about Indigenous history, and so that they're coming to work or interactions with patients with this foundational understanding of the trauma that people have endured over time and are still enduring, because I think that really, with that knowledge and dispelling a lot of the stereotypes that we have been led to believe over the last 100 years in Canada, really means that you come hopefully with less of these judgments that are tainting your care or influencing how you're caring for people. So I would say that's one of the most important policies at the moment that we could implement, is just making sure everybody has a baseline foundational knowledge base, so that we are getting rid of these stereotypes that have really impacted care and experiences, right, for families. Oh, Manitoba has outlawed birth alerts. That's great. Now that you've asked me that, I wonder if I'll go have a look and see what other provinces are doing.
I see, Michelle, you raised your hand. Did you have more to add to your question?
Yeah, thank you very much for this great presentation. It's sad and heartbreaking that this continues for so long. The reason why I was asking about policy changes, sometimes, people want to put in policies that are quite broad-based, but the nitty-gritty of things are not there. So even though everyone has this awareness, people are not necessarily doing things. I'm not in the NICU, but I'm wondering sometimes, knowledge is great, but something concrete like, and it seems silly and formal, but maybe something like, in a particular area, if there's certain Indigenous groups that have differing practices, almost having like a kit. We have something like that for different disease-based things where you have a kit. So it's great to have, like this understanding, but sometimes a little bit concrete to remind people, have this kit to kind of refresh you and do something. I don't know if something concrete like that has been enacted, or if it's helpful at all, or not.
I would suggest that there are hundreds of First Nations communities and more Métis and Inuit communities across Canada, and so to try to create something that's a one-size-fits-all is really not feasible unless you are working in a particular community. So I think actually, nurses, we all try to endeavor to provide individualized care, which is really what cultural safety is all about. It's asking, the people that you're caring for how they want to be cared for, not making assumptions that there are specific things that they would want just because they are Indigenous or identify as First Nation or Inuit Métis. So I think it's actually about, being comfortable asking your patients what it is they want, what they need, how can you best care for them. And as well, many people don't want to identify as Indigenous because of the potential risk that holds. But if you can share that the reason that you're asking is because there are Indigenous specific supports that might be able to help them, find groceries, get taxi money to the hospital, have, advocacy supports in place, or even be able to provide an elder at the bedside for ailing patients. It's trying to provide these supports while building that foundation of trust and letting people know why it is you're asking information or what you can support them with. I think that's also, I saw Ruth Lee. Hi, Ruth Lee. It's been a while. I asked about how you balance that obligation to report, and I assume you mean abuses, child abuse, but also avoiding the hurt. And certainly you can't avoid the hurt in those cases. It's going to be hurtful, right? But I think it's when our approach to involving child support or child services or child protection, when our intention is to support families, and we do that in a kind, caring way, but we first also have a relationship and build some rapport with families, and we're building on their strengths. It's not about punishing people for having inequities. It's about recognizing that they have some needs, and we need to put supports in place so that they can be the best parent that they can be. And so I think, it's how you come at that situation, which certainly happens. It's necessary in some cases, but also, many people don't realize that it actually is the law that these families are to have an Indigenous advocate present when there's child protection services involved. And so that means you need to know who are those people in your community so that when that happens, you can bring them in and they can be at the table for those discussions. And that just makes sure that they have somebody on their side who is present for those conversations. And that helps that power dynamic as well, right? So just scrolling through some of these. It's not a silly question, Michelle. It's a really good question. Thank you for asking it. I don't see any other questions here.
I don't see any other questions either. We still have a few minutes. If anyone wants to ask another question, you can raise your hand or put it in the chat. I'll just give another 30 seconds. See Michelle's comment, great job. It was a great presentation. Thank you both again. For everyone who joined, thank you so much for joining today. If you're interested to hear more on this topic, Dr. Wright will be speaking about community-led research with Indigenous communities, parenting in early childhood on October 3rd during our Bloomberg nursing rounds. I will include a link to register for that talk in our follow-up email if you're interested. I also wanted to let you know that our next Lunch and Learn will be on Tuesday, October 25th, featuring PhD candidate Laura Istanbulian speaking on supporting patient communication in the adult critical care unit during the COVID-19 pandemic. I'll also include a link to that in the follow-up email. And in closing, I'd just like to thank everyone again for joining us. Thank you, Dr. Wright and Rachel, and I hope everyone enjoys the rest of their day.
Thanks again for having us.
Thank you.